Introduce Professor Paul Mitchell, AO, who really needs no introduction. We are all very well familiar with Professor Mitchell. He is the Director of the Centre for Vision Research at the Westmead Institute of Medical Research. He's a Professor of Ophthalmology at the University of Sydney and works clinically as a medical retina specialist at the Sydney West Retina, where his clinical focus is managing AMD, diabetic retinopathy, and other vascular retinopathies. Professor Mitchell has made significant contributions in the field of public health and ophthalmic epidemiology via the landmark Blue Mountains Eye Study, with which we're all very familiar. He has co-authored over 1,100 papers in peer-reviewed journals and 75 books, chapters, or letters, and has attracted more than $30 million of research funding over his illustrious career. His team will be conducting the second National Eye Health Study commencing late 2021. I'd like to welcome Professor Mitchell.
Thanks very much, Sabine, and thanks very much to the MDFA and Luxottica for inviting me to speak tonight. The topic is detection of neovascular AMD using OCT and OCT angiography. Now, you know, I know that most optometrists have access to retinal photography, and increasingly, you also have access to OCTs. OCT angiography is simply around the corner with OCT. All the new OCT machines will really come with an OCT angiography module, which is really very little extra expense. And I think it's really going to, the thing that will change optometry, as it is changing ophthalmology, is this new imaging which you'll have at your fingertips in terms of being able to understand what's happening to your patients and helping us really to achieve better outcomes in the management of retinal disease. Next. So why is neovascular AMD so important? It's still the leading cause of blindness in Australia. It's been the leading cause of blindness in Australia really for the last century, and it's still the leading cause. We know that first eye involvement occurs, and then second eye in more than 2/3 of cases over time. So the highest rate of getting it in the second eye is fairly early after the first, and it diminishes progressively over time. So generally, the second presenting eye has the better starting vision. And that makes sense because people don't present so quickly for their first eye. And so it's the second eye that we've got the best chance of getting a really good visual outcome. We know this disease is currently treatable with 2 PBS-listed agents, Lucentis and Eylea, and a Beovu is also now going to be listed for second line. Treatment is needed indefinitely at variable intervals. That means really until people are close to dying. Otherwise, the disease recurs. And importantly, we know that about 1 in 4 are quite injection intensive. That means they need their treatment maybe 4 to 5 weekly, whereas the others can be stretched out to 8, maybe 10 or 12 or even longer in terms of weeks. And we know that if you're injection intensive in the first eye, you'll be injection intensive in the second. But with adequate treatment, a large proportion of people maintain their starting vision or close to this level. The problem is that PBS data show that many people stop treatment. By the end of year 1, it's over 25%. And by the end of year 2, it's approaching 50%. And now this is a terrible outcome for a blinding disease. We know there are multiple causes for this. Something, you know, they're related to the tyranny of distance, comfort, you know, frailty, a whole range of things. But out-of-pocket cost is a major and key contributor. And so I'm telling ophthalmologists they need to take responsibility for the follow-up of their patients. And I think you as optometrists can help this. Next. So what about vision impairment? Population studies in the past, including the Blue Mountain study, all indicated the threshold for the impact on vision impairment was the visual acuity in the better eye worse than 612. That's the level below which independent living begins to be compromised. So there's below that level, there's a stepwise impact with worse vision. And we know that's the level you need to drive. So we need to target that level, 612 or better when treating eye disease. We frequently fail to achieve it. For example, in typical treatment of neovascular AMD, and the trials really show that only about 1 in 3 patients treated for neovascular AMD achieves a visual acuity of 612 in the longer term. And we should be aiming for 2/3 or even more to hold that level. And by much better earlier diagnosis, this is where you come in, and better adherence to therapy, which is where you can also help. So optometry has a key role, detecting neovascular AMD at the earliest possibility, particularly in the second eye, referring these patients rapidly and identifying people who've stopped so that they can be somehow got to somewhere where they can restart. Next. So these are, I conducted the Blue Mountains Eye Study with my team many years ago, and these are the impacts that we found. So vision impairment in the better eye, worse than 612, down to 660, not blindness. There was a 3-fold increased risk of falls. In the 2 years after we did it, there was an 8-fold higher hip fracture risk. And we know this is a way that many older women leave this world. There was a 4-fold higher odds of the need for community support services. Patients with vision impairment were more likely at relatively younger ages to need premature nursing home or hostel care. There was a major impact on quality of life, similar to the systemic conditions listed in red below. People self-ranked their health relatively poorly if they had vision impairment. There was greater depression and increased mortality. You know, you think, well, how would vision impairment double the likelihood of people dying? You have to think about it, that if you've got vision impairment, particularly significant vision impairment, you probably can't read the bottles so carefully when you're having your medication. You don't get out as much. You probably don't get to see your GP as much. You probably don't exercise as much. You're more likely to fall in a hole and break your hip, etc. So this has been shown in many studies. Vision impairment actually increases the risk of dying. The corollary, of course, is that if we can reverse vision impairment, like with cataract surgery, you can improve survival. And we showed in 2 studies that was the case, and that's been now shown elsewhere. Next. So what happens if you don't treat neovascular AMD? You know, Tien Wong and I, some years ago, did a meta-analysis of all the trials, you know, where there was no really effective treatment. And there was like 28 were randomized controlled trials and 53 studies altogether, over 4,000 people. And you can see by 2 years after diagnosis, more than 3/4 were blind. Next. And you can see how this happened. You can see at the left, the red and purple bars are the ones who are blind, maybe a bit over 10% at baseline. That's 660 or worse. And you can see by 3 months, that zooms up. By 12 months, it's very high. And if you look at by 2 years and 3 years, the proportion who are blind really, or very poor vision, really is the vast majority of people with this disease, at least those eyes. Next. Yet Mark Gilley's study, the Fight Retinal Blindness Registry, has shown that if you keep treatment going, early, intense, and frequent injections, it stabilized the long-term vision. So you can see there was about a 1 and a bit line improvement after starting treatment, and that was maintained for 6 years and then dropped off at the 7th. But basically, we've shown now, many years later, we can hold vision in a large proportion of people. Next. Now, but the problem is, once you got past 12 weeks, a lot of people had a recurrence. Next. So if you stop treatment, and we saw this in COVID, many people have a recurrence and they lose vision. And every time you have a recurrence, you get more fluid, more scarring, fibrosis, and permanent vision loss. This lady, this was when ranibizumab first went on the PBS in Australia. And this is the old time domain OCT. 2007, she was 77, 618 vision, classic universal at the macula. Next, and you can see what happens over the years. This was 2008, 2009, 2010, 2011, 2012, 2013. Her vision went off with cataract. We did that. Next. And you can see her vision recovered again to 6.9. And it's never been really any different. 6.7.5, 6.9. We saw her at the end of last year when she's 90. You can see her 61st injection, and she's still 6.9 plus, and it looks fantastic. Her other eye is blind from macular degeneration. So this has kept her independent over that time until into her 90s. Next. So these are the questions I thought we would address. What are the OCT features of early, that's non-exudative AMD, of dry, atrophic AMD, of wet, exudative AMD? What are the OCT angiography features of exudative AMD? How do these signs correlate with the appearance? How does the CNV that we see on OCT-A evolve over time and with anti-VEGF? What about subclinical, non-symptomatic CNV lesions? And that's where you can come in. And I talked to you about this, that you can detect this very easily on the OCT. And what are the guidelines for referring patients with AMD lesions to ophthalmologists? Next. So this is a patient who's 73. You can see she's got soft, softish looking drusen at each macula. And this is the OCT appearance of someone with drusen. In the left eye, you'll see there's a drusenoid detachment where the drusen have clumped together. Next, you can see 2 years later, she became symptomatic in the right eye. She's now got a bubble of like a serous bubble of pigment epithelial detachment just nasal to the fovea. And at the fovea, there's a sort of irregular elevation of the pigment epithelium, probably like what we'd call fibrovascular. Now, next, she was symptomatic. She was, and this is the same time, and she was actually commenced on treatment. Next. And this is, actually, she was hesitant about starting, but we actually did start shortly after that last image when the disease got a bit worse. Now, what happened then is that she had her 3 treatments and she was basically lost to follow-up. She got a bit bored because she was seeing well out of her left eye, and so she stopped treatment. Next, so you can see what happened. We chased her, but she didn't really follow. And you can see because she stopped treatment, she then got a fibrous scar at the macula. We just go back, Sabine, to the previous one. So this was the PD January 17. Next, this is a year later after having stopped treatment for a few months. And you can see she got a fibrous scar. And she came in at this time because she started to lose vision in the left eye. And the left eye now got this large serous PD. Next. And we did a fluorescein that didn't really show. It showed that little window defect nasal to the macula. But I have to say, we were very concerned that she's going to go the same in this eye. So we did start treatment in the left eye. And she's been quite good. She's actually held the vision in that eye since. Next. One of the patterns you'll see when you're looking at drusen in the retina, and this is the opportunity of the wide field photographs, which many optometrists have access to, showing this almost like a carpet of drusen material. And you can see it's more prominent just above the disc and above the arcade. It extends out beyond the arcade, and this is the so-called reticular pseudodrusen, which occurs in about maybe 10 to 15% of people with early AMD. And she developed neovascularization. She was treated, and this disease is very likely to cause atrophy. And you can see the transillumination defects on the OCT below from that atrophy. The right eye, the fovea is in the middle of two atrophic areas, so she still has 6/9 vision, but we are concerned that this may not last in the longer term. She'd been on treatment since the early 2000s and has held vision in both eyes at about the level she started. Next. So what about the features of atrophic AMD? Next. So this is a patient in 2018, and you can see we'd actually had her on treatment for the left eye. Her vision's very poor. We've kept it going because we just thought it might help to prevent the development of a really large scar. But the basic pathology here, as well as subretinal fibrosis, which you can see on the OCT, there's transillumination defects through showing the loss of cells, and you can see visible choroidal vessels within these areas and some crystalline structures at the edge. It wasn't always like that. Next, 5 years earlier, this is the appearance in her right eye when her vision was reduced, and you can see there was if you look on the OCT on the right-hand side, there's a bit of a fibrovascular PED type appearance. Now, there wasn't a leak on fluorescein, and in those days we didn't treat. We thought, well, maybe this is not too bad, and we could watch this. This is not definite choroidal neovascularization. But I reckon if we'd had the OCT-A then, we would have seen that she does have, in fact, a new vessel under that shallow pigment epithelial detachment. Next, this is a year later. No real change. The PED on the top right is now a little bit more linear and looks a bit different. Vision is dropped a little bit further. Didn't treat her then. Next. And you can see what I've done. We followed her at regular intervals, humming and hawing about whether we should start treatment. You can see the PED flattened, and then by 14, it's flattened completely, and you can see transillumination defects with the atrophy developing. And then by 2015, she develops really symptomatic changes. Vision drops even further. She gets fluid in the retina. So if you really think about this, you know, and knowing what we know now, then we would have started treatment earlier, and we probably or possibly could have held this for longer. Next. And so this is the appearance in 2015. She had a definite new vessel on the fluorescein angiogram, but previously it didn't show this. But you will see that we can pick up these new vessels earlier. Next. This is the other eye at 2015. Of course, we actually had already started her treatment earlier on, and that's continued, but she did lose vision from progressive atrophy. Next. What about the OCT features of wet exudative AMD? And you've seen some of that already in the last case. So here is a man who has got hemorrhage, an area of elevation just above the left macula. And you can see on the OCT, there's fluid, both intraretinal, mainly subretinal fluid. Next. And here's another person with CNV developing in his right eye. You can see there's an atrophic looking area nasal to the macula, and adjacent above there's where it looks like the onset of the new vessel, which is spread across the macula temporally, and there's hemorrhage at both at the inferior margin of it and temporally. And you can see on the OCT, there's now subretinal hyperreflective material, there's intraretinal fluid present. So this is absolute, classic diagnostic neovascular age-related macular degeneration on both the photograph and the OCT. This is after treatment for 6 months, and you can see that the fluid has gone away. There is a bit of fibrosis under the macula. The vision was maintained at about 624 at that time. Next. Another person presenting with neovascular AMD, although there's not much visible in the color appearance, when you look at a person on the slit lamp, you can see she has a shallow pigment epithelial detachment with an overlying neurosensory detachment. So there's subretinal fluid present, and of course, this is neovascular AMD. Next. This is 6 months. This is the same appearance, and you can see, just to show you what these vessels look like on OCT-A, that new vessel fills up exactly the space underneath that PED. Next. And this is the same appearance after 6 months of treatment, where the fluid is gone, but the PED, that shallow PED, often remains. It can flatten, but in many cases, it remains the same. But her vision is now stabilized and will continue to be stable if we continue the treatment. Next. This is a person with much more widespread drusen material, and she developed vision loss in both eyes at a relatively similar time. And you can see the OCT shows this shallow, irregular elevation of the pigment epithelium, as well as the drusen, which occupy the posterior pole. Next. And we actually did an OCT-A in showing that there is a big new vessel underneath this. Next. The other eye, highly symmetrical condition. And next, also with a new vessel on the OCT-A. Next. And this is recently when we photographed her again, showing the wide field appearance of someone with extensive drusen who has also gone on to develop neovascular AMD. Next. What about, let's just get, I've already shown you a few OCT angiography images, but let's look at how the OCT angiography is seen in typical wet cases. So this patient you saw earlier, he was 11-week history of symptoms. Pity we didn't get him earlier, because we would have seen him at an earlier stage. This is the fluorescein angiogram at the bottom on the Heidelberg, showing the images we get in the early phase, mid phase, late phase. But you can see on the OCT-A, and go back, it shows that the new vessel is arising nasal to the fovea, like a tree trunk, and it's it is elevating above and across the foveal area, almost splitting around the fovea. So this is one of the typical patterns of neovascularization. And in fact, most patients with choroidal neovascularization in AMD, the new vessel starts on the nasal side of the fovea. We don't understand why, but this is one of the characteristic features. Next. This is another lady. She's 73, a heavy smoker, and you know, we found in the Blue Mountains Eye Study that smokers got the disease 3 times more commonly and 10 years earlier. So if we see someone in their 60s, or early 70s, the first thing I say, well, how much are you still smoking? And invariably, someone who gets at the age of 68 will say, oh, well, I've cut down, doctor, but I'm still smoking a bit. And it's amazing. Apart from PCV in Asians, it's the main cause of getting this disease at a young age. So she'd been a heavy smoker, 6-week history, 636 vision. You can see almost a classic type appearance on the fluorescein angiogram. Next. And so this is the fluorescein angiogram picture on the left of the new vessel with the retinal vessels overlying it. And on the right is the OCT angiogram picture. And this is the outer retina choriocapillaris segment. You can see below that image of that vessel shows the retinal, like a B scan of the retina, showing the purple lines show the width of this segment that's been taken. And the flow, the red indicates the flow in this segment. So it's got a lot of flow. And there's already a bit of subretinal hyperreflective material, a bit of fibrosis starting. Next. So I thought this was a bit like Medusa. you know, I've seen this picture by Caravaggio. He was an amazing painter, and you can see she's had her head chopped off, but she's still looking down at you with that awful stare, going to turn you into stone, with that snaky stuff coming out of her head. So it really does look like a Medusa. Next. And this is one thing you'll learn to do with the OCT-A. You can program it so that you can take a segment with the retinal vessel showing, these are the projection artifacts, or without them. And you'll see in many of the pictures I show, we show the outer retina choriocapillaris layer with projection artifacts and without. And after a while, of course, we get used to looking at the retinal vessels as well, so you can orientate yourself well. Sometimes you can see detail better by taking them out. And that's just, you print out both, and it's easy to, you look it up on the computer and you can see the vessel very well once you remove them. Next. Now, this is another man. He's been treated, he was treated in the past, but he stopped treatment for all sorts of reasons, you know, mainly cost or whatever. And you can see his vision in the right eye had fallen to 6/30. He was 3/60 in the left because of old macular degeneration. Fibrosis was surrounding atrophy. You'll see the OCT-A shows that vessel, and I'm going to show you a blow up of it on the next slide. Next. So this is what it looks like when you look. It's almost like a dumbbell. It's coming on the nasal side, and it's extended above and below the macula, but around the macula. You can do these fancy pictures and have the different segments a different color, but I don't think that's so helpful. So I tend to stick to the black and white. Next. And I'm going to come back to that patient in a moment. Now, are there any lesions that stop you seeing a choroidal neovascularization? Well, the main groups are here. If you've got a big PED, this really stops you. You know, it's difficult to visualize them, but sometimes you can see them at the edge and usually the nasal edge. And progressive atrophy, once the atrophy extends into the macula, then it's very difficult to see new vessels. And I'll show you what happens as atrophy progresses. And of course, if people move and, you know, if you've got lens opacity, this of course will make it more difficult. But we found in people who had neovascular AMD, 85% you could actually visualize the CNV. So that's after taking out the people who've got atrophy and big PEDs. Now this lady, she's 62, Chinese, 2 months of symptoms, vision loss in the right eye. She's got that PED you can see on the OCT. And you can see the other eye's got some drusen, but not much else. I didn't show the OCT on the left eye there. These are the OCT images of the right only. So we go next. So I did a fluorescent angiogram at the top, and we did an ICG angiogram at the bottom, and you can see the ICG shows she's got these little polyps. So this is the polypoidal vascular choroidopathy, PCV, the Asian variant of neovascular AMD, which fortunately mostly occurs only in one eye. So this is not as visually damaging, but of course it's still worth diagnosing and treating. Next. So this is the same lady at that time. And we start, this is actually after treatment, her 5th treatment, still got the PD with some subretinal fluid. Next. And after treatment, you can see the polyps have gone on the ICG. So they did close on the ICG, and she was treated with Eylea, which I think may have the edge for PCV over Lucentis, but you know, both are effective in treating this disease. Next. And so with the PED, it's very hard to see these new vessels, but you can see on this upper right image of the, you know, this is the RP fit image, whereas the one on the left is the outer retina choriocapillaris. The RP fit image shows just on the nasal side of that circle. The picture above shows what looks like a new vessel invading that PED. Next. And this is a bit blown up, are showing, yep, it's a new vessel there, and there's the PD. This is after about 5 treatments. Notice there's also exudate at the perimeter of this PD, and that's a sign of chronicity. So she's probably had this for quite some time. Next. What about the effect of atrophy on these new vessels? So the top one, she's got a new vessel. Let's look at the bottom one, the left eye. You can see there's a transillumination defect through the choroid where that circle of atrophy is present. Next. And in the left eye, you can see the only new vessel that's present is the bit at the edge of that atrophy. You can imagine that maybe a year before she got the atrophy, the new vessel would have been across the whole macula. But here it's retreated to the edge where the atrophy is not present. And as the atrophy expands, that new vessel will become less and less visible. Next. And that's a blow up of it. Next. And that's another one where it's been on treatment for 2 years, now becoming a bit atrophic. Next. You can see the new vessel is just at the perimeter of this. It's just about gone. And over time, it will become invisible. Now, the question then is, maybe in these atrophic patients, we could stop treatment. At the moment, the default is to keep going. But, you know, you could do a study, and we've designed such a study to actually, using OCT-A control, stop people in a randomized control trial and continue in the other group. And we haven't had that funded yet, but I think it's a good idea because many of these people probably could stop therapy. Next. This is a patient, he was 77, she was 77, and you can see she already had peripapillary atrophy. You can see at the macula, she developed subretinal fluid, a little PD, some intraretinal fluid, and there was a new vessel just above a nasal to the macular area, but it involved the macula. So we started anti-VEGF. Next. And then when we had OCT available, and this is when I first had it available in 2018, that atrophy had increased dramatically. So we couldn't see the new vessel because the choroidal vessels are just, the normal choroidal vessels are now visible, and we can't see the abnormal neovascularization within that zone of atrophy. But amazingly, because the center of the fovea is not completely involved, vision is still holding at about 624, and we've continued treatment. Next. So what about the correlation with the appearance? And this is actually quite useful. And kind of what about the different CNV subtypes? I'll just start with the second bit first. Next. So we know that CNV has been divided into the first type, occult. And these are under the pigment epithelium. They're poorly defined on fluorescein, and that's why they were called occult. Type 1, they're the common ones. Type 2, less frequent, are under they're subretinal, well defined, like those classic one you saw earlier, and this is called classic, well defined. And then less frequent are wrap lesions, which come from the inner retina with a retinochoroidal anastomosis visible usually from a venule coming into the lesion. Now, as I said earlier, all OCTs will soon have, if they don't have now, OCT capability. And the price of adding OCT-A is almost the same. So it means that you can participate fully in the detection and early referral of key in neovascular AMD patients. Next. So this is a patient who was 81. She presented here in 2014, had neovascular AMD in both eyes, occult type lesions. Next. And we followed her over the period. She was treated all this time. The treatment number is shown in the little numbers there. Treatment about 6 to 8 weekly. She had a fibrovascular, PD, a little bit of fluid over it from time to time, but both eyes kept vision extremely good. because you can see the vessel was mainly just outside the fovea. Next. And so in 2018, when OCT-A became available in my practice, we did it. And you can see, look, the right eye on the left eye on the right. You see there's this huge branching vessel, you know, on the right one coming from the temporal side, unusual, usually starts on the nasal side, and from the inferior area in the left eye. And you can see the picture at the bottom shows the sector from which this segment was taken. Next. So this is the appearance blown up. Now, if you look at the color picture on the left-hand side, this is what you would see when you're looking at her on the slit lamp. Now, those vessels, those funny-looking vessels, are actually the choroidal new vessel. You can see them on the slit lamp without an OCT-A. And that means that you can actually see it. It matches exactly the appearance on the right. Next. And you can see this is like just recently, 3 or 4 years later, it's hardly changed. She's still got good vision. We've been treating it ever since. And this means that these new vessels don't go away. So the aim of anti-VEGF is to suppress activity over the vessel. The CNV is now integrated into the macular circulation and nutrition. So you couldn't destroy it. You wouldn't want to destroy it because you destroyed the nutrition. So all you want to do is suppress the activity. Next. There's the other eye, 3 or 4 years later again, showing that the new vessel remains there and it's integrated. And her vision's still extremely good with treatment every 6 to 8 or so weeks. Next. And this is shown in this patient. He's 94, she's 94, and she'd been treated for 8 years. And the the OCT-A became available in 2018, so we did it. Showed this massive big mushroom under the macula. And you can see the pictures at the bottom. That B scan shows the vascular activity in this new vessel. It's very vascular at 636 vision. But look at the other eye. You've been treated with the other eye as well for the same period. Next. And her vision is holding really well. This is the right. You can actually see the new vessel on that picture. And the picture on the right. Next. And the same in the left eye. Even though she's got this fibrovascular PD, some overlying fluid, this mushroom-like huge new vessel, her vision is still 6/9. She'd been treated for 8 years. We've been continuing her treatment the whole time, and she's done really well. Next. And again, when you look at this is a red free, but it's the same on the slit lamp. You can look at this. You can see on the left picture the shape of that new vessel. So this is really the new vessel you're looking at when you actually look at her on the slit lamp. Next. Another person with type 2, a classic new vessel, just nasal to the fovea. Next. This is the OCT-A appearance. Next. And this is the different segments showing the effect. Next. You can again show it with the different colors, but I don't think that's quite so informative. Next. Now this is finally a wrap lesion. And if you look at the photograph on the left, you can see there's a venular branch that goes almost vertically into the middle of that lesion. And this is the key feature of wrap. And these are, unusual new vessels, type 3 CNVs. Next. That are breaking through. Next. And this is the appearance of a wrap lesion on OCT. Another wrap lesion here. Next. 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 Showing the huge frond in this case. So how do they evolve over time and with anti-VEGF? Next. So this is the patient you saw earlier who had 11 weeks of symptoms. 6:30, we started treatment. Next. You can see 4 weeks, that tree has been pruned a little bit. Not much, but a little bit. Next. It's still sort of around the fovea. The fovea is in between those branches. And this is for 18 months and 4 years. But it stays there, but maybe it's not quite as, friable looking. It's a little pruned, but it's still there. Vision over 4 years, still 618 minus, doing really well. Next. And this is that same patient showing the OCT at the bottom. And I show you what it looks like when you try and line them up. Next. So here we've lined up the vessels exactly. So that's where the new vessel is on the OCT-A on the color photograph. And of course, it's underlying, if you look at the OCT on the right, is that fibrovascular PD includes exactly the new vessel. Next. Now this lady here, you remember she was the one with the medusa. Next. That was the appearance. Next. So you can see what happened after treatment. Her medusa went to a tree. So a lot of that stuff went away and she was left with the tree. Next. This is like 3 years later. The medusa's gone, but she's still got that tree. I mean, 624, but she really is doing well, but got some fibrosis. Unfortunately, she had that right in the beginning, but her vision's still better than when she presented. Next. What about what about subclinical vessels? And this is one of the most interesting bits, I think. And this is a lady who presented in 2015 with a hemorrhage in her right eye, neovascular AMD. Next, symptomatic, started running a bit symptomatic. And you can see she had a subretinal fibrosis. Vision wasn't great. Next, but it held. It held. This is 2018 when I first got the OCT-A. Next. And it showed a big frond present. Next. What about the other eye? We'd been following the other eye. She had no change in vision. The vision was 612. She didn't have any absolute leak on the fluorescein. And we decided not to treat her at that time. Next. And you can see this is 3 years later. No change in vision, 612. Next. But we did the OCT-A. And you can see in between, these are the OCT images. Next. But she's got a big frond. Still asymptomatic. Next. Finally, she then became symptomatic in 2019 when she got a hemorrhage with fluid, subretinal fluid. Next. And you can see this is the ICG showing she had polyps. Next. And next. And you can see there's an extension of that new vessel to the temporal side. So we started treatment at that time. Next. So that double layer sign has been described by Phil Rosenfeld, who was originally a Japanese ophthalmologist, first described it in PCV. And so it's a shallow elevation of the pigment epithelium, and often a completely normal vision. Next. So this is a person on the left whose other eye has got symptomatic neovascular AMD. The right eye has got the shallow sign and has got a CNV on the angiogram, on the OCT-A. The one on the right is another person with also a CNV on the OCT-A. Next. Same person here, right eye, another one with the right eye showing again. These are the fellow eyes of patients with CNV that's symptomatic in the first eye. Next. So they've all got this shallow elevation of the pigment epithelium with a new vessel, but they're asymptomatic. They've got good vision. Next. And so we found in our series, it was 1 in 8 fellow eyes had this. So 1 in 8. And it's now been shown it's about 4 to 10-fold more likely to get symptomatic CNV if you've got an eye with that than without. So this is a risk sign. This means that a person at risk of progression, and they can be followed closely by you or by us. And of course, With an OCT-A, you can see if it changes, but mainly to see if they get any symptoms, retinal fluid or hemorrhage, or or a change that would indicate the need to start treatment. Next. So firstly, do no harm. We're not treating these at the moment unless people become symptomatic, but it's actually an important issue. And these are the sort of people, you will see these all the time, and you'll be able to say, he's got this probable subclinical new vessel, or you may be able to, and he'll need really close follow-up. And you can help us in monitoring people very closely and working out the best time to start treatment for these patients, because many of them will progress. Next. So what are the guidelines for referring patients with AMD lesions? Next. Look, there are all sorts of guidelines, but I would say if you've got definite clinical signs of neovascular AMD, hemorrhage, fluid, you really need to get the patient in 1 to 2 weeks. This is an ophthalmic emergency. We make a policy of seeing people, that week or the same week, that week or the next week. Typical symptoms were without confirmatory signs. In other words, someone's got distortion, a scotoma. Well, 1 to 4 weeks. I mean, they need to be seen relatively soon. Absent symptoms, but those suspicious features like that double layer sign or PD, again, maybe 1 to 4 weeks. And you will see many people who've been lost to follow-up. They started treatment, couldn't afford to keep going because of the out-of-pocket costs, and you really need to get them back to an ophthalmologist to continue treatment in 1 to 2 weeks. If you've got extensive early AMD signs with some visual symptoms, maybe 2 to 6 weeks. And if you've got atrophic dry AMD with a recent change, obviously 2 to 6 weeks or something like that. And in people who don't have AMD, who get CNV like myopia, dystrophies, previous central serous choroidopathy, I mean, quickly, that week or the next week. Next. So just to summarize, 85% of the new vessels are visible. 1 in 8 have a non-exudative subfoveal CNV. And next, I'd like to thank you very much for the opportunity to talk tonight, and I'm happy to answer any questions you've got. That's probably more than you ever wanted to know about OCT-A and AMD, but I hope you found it enjoyable.
Thank you so much, Professor Mitchell. I think that was fantastic. I can't believe the number of slides that you got through in that time. A short segment about the work of the Macular Disease Foundation Australia.
Macular Disease Foundation Australia is the national peak body representing Australia's macular disease community. We are guided by 4 important pillars of work: prevention and early detection, patient support and services, advocacy, and research and data. As an eye care professional, you know there are many conditions that can affect the macula. The most common of these are age-related macular degeneration, affecting approximately 1.4 million Australians, and diabetic retinopathy, affecting over 300,000 Australians. Of the 8.5 million Australians over the age of 50 who are at risk of or living with macular disease, it is estimated that 1.7 million Australians have some evidence of the disease. So why refer your patient to MDFA? By working together, we can save sight. Early detection is critical and has been shown to improve patient outcomes. At MDFA, our purpose is to reduce the incidence and impact of macular disease. By referring your patient to MDFA, you ensure they are better supported to improve their understanding of their condition, to minimise their risk factors for disease progression, and maximise their ability to live optimally. When you refer a patient to MDFA, they will receive individualised support to manage their condition, appointment reminders and tailored care plans, the right information at the right time to support the patient journey, access to important health education and resources, co-developed with some of Australia's leading retinal specialists, nutrition, lifestyle and wellbeing coaching, peer-to-peer support, and help navigating the NDIS, My Aged Care, and low vision providers. All of our services are administered by qualified staff and are free of charge. To assist you and your practice, we offer free CPD, a range of evidence-based resources and, of course, quality non-clinical support for your patients. We can further assist you by encouraging patients to return for regular eye exams, emphasising the importance of continuity of care, treatment adherence, and recommending their at-risk family members also get tested. Your job is to provide important clinical assessment, care, and referral. Our job is to provide immediate and lifelong information and support and coaching for patients, their families and carers throughout the entire journey of their macular condition. Together, we can have a long-lasting positive impact on people's quality of life and promote better patient outcomes for those living with macular disease.